Thank you. Good morning, everyone. Slight technical hitch here. It's my superpower. Right, oh, there we go. Next slide. In May 2020, I joined this Facebook group, and I was 6 weeks into COVID, and I wasn't better yet, and I thought I was some kind of freak. And I was really pleased to find other people who also weren't better. And back then, we were counting our symptoms in days, and this has gone on now for hundreds of days, months, even years for some people. When I joined the group, there were a few hundred people. The group was growing, so I offered to help with admin. And the group has now grown to over 41,000 people in over 100 countries and territories. And the admin team has grown to over 20 people in 5 time zones. And that group then became Long COVID Support. We coalesced with lots of different people that we found online. And we're now calling ourselves, we're a charitable organisation called Long COVID Support. I should say I'm not the founder, I'm a founder. There are many of us. And we're by no means the only group. Coronavirus Worldwide has over 70 groups in over 25 countries, and that's just on Facebook. There are other groups on other platforms. For the story of what happens when a new human disease arrives in a world of internet and social media, and what can be achieved by sick people in their beds in a very short space of time, this story is told by Felicity Callard and Elisa Perego. And they tell the story of how we've done what we've done as patients. I set up this separate Facebook group called COVID-19 Research Involvement Group, separate to the support group, because I perceived that research wasn't here yet, but it would come. And I wanted a space where we could talk with investigators and they could speak to us, people who'd had COVID, and we could share research and talk about what was coming up, recruit to trials and get involved. And that group now has over 2,000 members. But we didn't wait for research. I mean, we were quite excited when the Department of Health announced funding for research last summer, but it turned out to be post-COVID. And that was just for people who'd been in hospital. And those of us, which is the majority, who hadn't been in hospital with our COVID, were left going, well, do we just not exist? What about us? We need research as well. But patient groups didn't wait for professional research to come along. So even back before anybody really had acknowledged that this condition was a chronic condition, people in patient communities were doing research. Like Jez Medinger, if you want a kind of evolution of what are the questions that we've been asking ourselves in our group, have a look at his YouTube channel. The Body Politic group in the States gave rise to the Patient-Led Collaborative. Long COVID SOS, another UK group, have just done a vaccine survey. And we have an ongoing clinic survey running on our website. And this is just a taster of it. There are many more out there. The Patient-Led Collaborative group were actually the first to report on long COVID before we were even calling it long COVID and before the medical establishment had actually really even acknowledged it existed. Back in May 2020, they produced this report on 640 of their members. They followed that up with a 7-month report, which is in preprint, but I'm told is going to be peer-reviewed. And for their story of how they did what they did, there's this journal article. Back in the end of summer last year, we started talking to ISRIC. I'd never heard of ISRIC, and they knew long COVID was coming. When they wanted to speak to us, it's because they knew that there would be a chronic condition, because there always is in a viral pandemic. And we said to them, look, we could do with presenting to the research community about our priorities and what we're finding in our groups. So we teamed up with Glopidar and we developed a long COVID forum, which took place last December. And in this, we talked about our research priorities. And not only the conference, it was really important to us to not just have a conference, but to have follow-up with a Lancet letter and this BMC medicine paper, which sets out the priorities that we identified at the conference. And we've gone on to co-create and co-author work with ISRIC and with others, and some of these are on our website. FOSS COVID is working with the James Lind Alliance to do a priority setting partnership. and I'm told that this will report soon. It's been expedited. A GLA PSP would normally take a couple of years, but they've already had the final workshop and they'll report soon. With health data research, we have a few issues with some of the research which has come out from health data. There's a tendency for doctors to think that a large sample size means that something's really good. And we all know there's no getting past a poor methodology. If your methodology is not great, there isn't a sample size that will cover up for that. But a lot of doctors aren't research trained or statistics trained, and it's really difficult for patients to push back against the big journal article in the New England Journal or the Lancet, which says this is what this disease looks like. And there's a direct line from that to a patient sitting in their doctor's office saying, but my symptoms are like this, and I'm not better, and it relapses and remits. And the doctor's saying, oh, but the research says that this illness is like this, and you must have something else, and maybe it's anxiety. And this happens. It does happen. So it's about perspectives. You need the correct perspective to make sure that you don't introduce false assumptions into your work. And I apologise to my fellow physicists for this joke, but I thought it was funny. And when I was working as a physicist, if I developed a model for a physical reality, I had to check against the physical reality with real measurements. And if my model didn't match the measurements, I assumed that my model was wrong. I didn't assume that the laws of the universe had changed. But in health data research, I feel like there's a curious lack of validation often. So a model is presented of disease, but there isn't a bit where it says, and then we went back and checked with a large patient community to see if that squared with their experience. And some of the early work, we just felt, we were reading it thinking, we were pleased there was long COVID work, but it just didn't feel right to us. It just didn't feel as if that was what we were going through. And I know that we don't have the full picture either. We've got biased samples. We can only talk to people on social media. We don't have any money. That's why we use social media and survey work, because we haven't got any resources. And we need the resources of professional science to find the people that we're not talking to, the populations that are out there that have their own priorities potentially. But there are false narratives that get baked into some of the models, some of the health data models. And the first false narrative was that you would recover in 2 weeks, which was obviously wrong. But new false narratives come along, such as it's only a respiratory disease, or children aren't affected, or it's only people in hospital that get long COVID, or so on. And it's really important for health data research to not bake in a false narrative into your model, because then the model doesn't reflect our reality. And this disease lives in our bodies and in our lives. And if a model doesn't reflect that, then what is it for, and what potential damage might it cause? So one of the first pieces of work which we felt really, that really squared with kind of what we were finding in our groups was the ONS. And some of us had met Ben Humberstone at NHS Income Task Force meetings and had follow-on conversations to try and build in our experiences into the work that they were doing, to talk about the symptoms that nobody was talking about, and to try and get something a bit closer to what might uncover some of the experiences that we were having. So this data was, was welcomed by people in our groups as being a bit closer to what we felt as if was happening. And this is a well-worn phrase, but it does say what we mean. In healthcare, as far as the NHS are concerned, they say there should be nothing about us without us. There should be no healthcare development without patient involvement. But for research as well, there should be nothing about us without us. And we would really urge you to get involved, properly involved with the patient. It's not just about engagement. It's not just about telling us what you've done. It's about having us at the table to co-design the research in an iterative fashion, to keep out those false narratives and make sure that the work actually works for us and is beneficial to us. Fortunately, we're really easy to find and we're quite friendly. And we're all over social media, and we have been for a very long time. And this goes not just for long COVID or COVID, this goes for any patient community, for any health condition. There will be people out there who will be happy to give you the benefit of their wisdom and what they've learned from their communities. And with that, I'll leave you, and thank you for your attention.
Margaret, absolutely terrific. I'm going to give you a round of applause. I think that's absolutely fantastic. And thanks for all that you're doing, but also for reminding us about applying the laws of physics to health data research, which I think is a great point.